Good afternoon, everyone, and welcome, and thank you for all joining us today for our April Arizona Community Grand Rounds on congenital syphilis in Arizona, best practices, prevention, and treatment. This is incredibly timely and a very popular topic, so we're super excited to dive into the session today and hear from our fantastic experts. I'd like to first take the time to introduce the team of speakers who will be sharing their insights with us today. So first off, we have Becca Scranton, who is the Deputy Borough Chief in Infectious Disease and Services at Arizona Department of Health Services. She started her career at ADHS in 2017 as the syphilis epidemiologist and has had the opportunity to work with local partners to improve surveillance, testing, and case investigation training opportunities in Arizona. In her current role, Becca works with the Bureau Chief of BIDS, to support 5 infectious disease offices composed of over 100 staff and contractors. She directly supervises the office chiefs for the Office of Rapid Response Disease Investigation and the Office of HIV and HCV, so services. In her free time, Rebecca serves as the chair of the National Coalition of STDs, as the director, and is on the board of directors for NCSD. So also joining us today is Rachel Gordon. She is a clinician at the Pima County Health Department. She's a family nurse practitioner specializing in family planning and STD or STI infections, treatments specifically around HIV and syphilis. She's been with PCHD for the last 3 years. She's completed her Bachelor of Science in Nursing at the University of Memphis in Tennessee and is a Wildcat, so yay Wildcats, who earned her Master's of Science in Nursing at the University of Arizona. She holds a national certification with the American Academy of Nurse Practitioners with a minor focus in rural health. Rachel has practiced in Tucson for 20 years and is passionate about the prevention of STIs or STDs and supporting individuals in crisis. So thank you both for being here and taking the time to speak with us today. On the next slide, I'm just going to go over a quick financial disclosure. All planners and speakers, presenters of the training about to take place have no relevant financial relationship to disclose. So Arizona Alliance for Community Health Centers is accredited by the Arizona Medical Association to provide continuing medical education for physicians. The Arizona Alliance for Community Health Centers designates the Arizona Community Grand Rounds Congenital Syphilis in Arizona best practices for prevention and treatment educational activity for a maximum of 1 AMA PRA category credit. So at the end, we'll put up a QR code for you all to be able to get credit for today's session. Please feel free to use the question and answer function to send questions our way. After each of our presenters provide their initial comments, we at the end of the presentation will begin with the Q&A portion and answer questions. With that, I'll turn it over to our esteemed panel, Becca, to get us started. Thank you so much.
Thanks so much. Hi, everyone. My name is Becca, and I work for our Bureau of Infectious Disease Services at the Arizona Department of Health Services, which is really just a big way of saying I do a lot of infectious disease stuff, inclusive of syphilis. Next slide, please. So the objectives for my portion of the talk today are to provide an update on where we're at in terms of syphilis trends and current statewide screening recommendations. I'm going to highlight some best practices for implementing screening in the ED setting, and I'll share some resources to support testing and treatment recommendations in Arizona. Next slide, please. So if you haven't looked at our congenital syphilis numbers, they have been rising for years now. When I first started with ADHS, we were averaging about 14 cases a year, and that was for the average for about 10 years. In about 2016, 2017, things started to change drastically. We are now seeing well over 200 cases of syphilis in babies every year in this state alone. Next slide, please. And as high as that increase is, those baby cases only represent about 3% of our total syphilis case volume. So syphilis is a really, really huge infectious disease problem across the state of Arizona. We do continue to see the majority of our cases in males, but an increased proportion of cases are occurring in females between the ages of 15 to 44, which is one of the things that is driving this current trend that we're seeing in babies specifically. Next slide, please. We're not alone in this. What we're seeing in Arizona is what we're seeing across the nation. So while we are starting to see more and more syphilis in both urban and rural parts of our state, we're also seeing this pretty much spread all the way across the nation. Next slide, please. While we are not alone in this, we are unfortunately leading the pack. We are top 5 for congenital syphilis. We've dropped off a little bit in rate because everyone is increasing at a rapid rate for congenital syphilis, but we still remain in the top 5 and have a significantly higher incidence of congenital syphilis than the rest of the United States. And I alluded to this earlier, back in 10 years ago when we were seeing only 14 cases a year, the majority of those cases were in Maricopa County, where the majority of our population resides. That is not the case anymore. We see syphilis in every county in Arizona, and we see congenital syphilis in every county in Arizona. So no matter where you live, work, play in Arizona, you will find syphilis if you look for it. Next slide, please. So a lot of folks want to know, how did we get here? Well, syphilis is really, really sneaky. It's called the great imitator because those initial signs and symptoms, first off, they don't look like an STI generally, and they're easily missed. That first sign of syphilis occurs in the primary stage, and it is a painless lesion that occurs at the site of infection. So for persons who engage in receptive sex, like vaginal sex, that site of infection is going to be in the internal anatomy in the vaginal canal. So we often are missing cases, especially female cases, in those early infectious stages, leading to increased transmission in our communities. And while secondary symptoms are a bit more diffuse and you've got some telltale signs and symptoms like palmar plantar rash, still the rash can look like a lot of different things or may not be present at all. So again, these secondary symptoms, while they're there, they're often missed as well, and they go away on their own without treatment. But the long-term outcomes of untreated infection like congenital syphilis, syphilitic stillbirth, neurological problems, ocular problems, those can happen at any stage. So screening is really, really important for detection, and treatment is really, really important for disruption of transmission. So those are 2 really critical tools that we'll need as we move forward with trying to combat syphilis in our communities. Next slide, please. So we do have some requirements for screening in the state of Arizona. As part of our administrative code, we are required to test for syphilis at the first prenatal exam. That's been on the books for years. And it's really, really helpful for those who are in prenatal care, right? In 2003, when we had our last little blip of syphilis, which it is a blip compared to today, we saw a lot of syphilis in Maricopa County, and that prompted a board order for 3rd trimester testing and testing at delivery. That board order has been renewed every year. And in 2018, when we started seeing an increase of syphilis in females between the ages of 15 to 44, we started to extend that board order through an update to our administrative code. So as of 2018, now as part of our code, we're required to test for syphilis at early 3rd trimester, so 28, 32 weeks, and again at delivery. And these remain really, really important strategies for identifying cases and linking folks to treatment before we see those really negative outcomes of infection. Next slide, please. So while those strategies are important, it's still not quite doing enough to control the rise of syphilis. So historically, people only got screened for syphilis in the last 10 years if they had a known risk factor, if they identified as a man with male sex partners, or if they were pregnant, which meant that we kind of missed that jump into the non-pregnant female population and men who have sex with women. So for that reason, CDC now has released updated guidance. They released this in 2023. What year are we? 2023. They released updated guidance to test all people in that age range of 15 to 44 if you are in a region where your primary secondary syphilis rate in females between the ages of 15 to 44 is more than 4.6 per 100,000. Well, naturally, we're above the US rate. Naturally, we're above the rate of syphilis in females 15 to 44. Our rate is 26 per 100,000. So we extended this recommendation for screening all people 15 to 44 to the entire state of Arizona. Next slide, please. We also take a look at the risk factors in our maternal population to guide our screening recommendations here in the state. A couple of the things that stand out from our data, about half of our maternal cases do report some form of substance use, with the top two substances being non-heroin opioid use. This really increased in 2020 during the pandemic. Previously, it was much, much lower. And meth use, which has been a strong indicator since we were seeing the increases way back in 2017. Not all of our cases report risk factors. Many of them report zero risk factors, which is why we're using a more broad approach with our screening recommendations these days. Another key risk factor is a lot of these women do not have access to prenatal care. 38% do not have access or have very, very late engagement in prenatal care. However, one touch point that we do see while people are pregnant, and certainly before they become pregnant, is the ED setting. 31% of our delivering syphilis patients who have no prenatal care have at least one ED visit during their pregnancy, let alone the other points in which they may access care. And then about a fifth of our cases do report unstable housing. This isn't necessarily that they're living on the streets full time. We do see a lot of couch surfing or living with partners and family among our maternal cases specifically. So that kind of influences where we target our interventions depending on where we're at in the state and what we're seeing in that region. Next slide, please. So I alluded to this earlier. All of this prompted us to ramp up our screening recommendations in light of the ongoing transmission that we're seeing across the state of Arizona throughout many communities, some who have no risk factors at all. We now recommend that we screen all sexually active individuals between the ages of 15 to 44 annually for syphilis. We also recommend the implementation of syphilis opt-out screening in the ED and urgent care setting for pregnant and women of childbearing age. And in those settings like ED, where you're not necessarily going to be following up with someone after you see them in that initial encounter, we recommend the use of a point-of-care test and same-day treatment. That initial dose of treatment is really, really important for preventing that person-to-person transmission that you get in those early stages of infection. And public health can take care of the rest for those cases that need the full 3-course treatment. So, next slide, please. I do want to take a pause because I've gotten a lot of questions about what does opt-out testing mean in light of these updated guidelines. So there's a lot of ways that you can operationalize opt-out testing. It is a way to destigmatize a service and also still respect patient autonomy to refuse a service. So you do want to inform clients that they're receiving the service. You can do it verbally or in writing. This is a sample text that was adopted from what other entities have used in publications around opt-out testing for STIs. You kind of couch the practice in why we're doing it, which has less to do with individual behavior and more to do with the overall high rates of syphilis we're seeing in our communities. And you explain the services that's being provided, and you keep that door open for questions about the service. And that is the way to kind of create space for that patient to decline the service if it's not something that's in alignment. It also creates a great educational opportunity about, what we're seeing in our communities in relation to the current syphilis rates. Next slide, please. So additional settings where this type of opt-out testing model can work really well include correctional facilities. We see about 21% of our overall syphilis cases in correctional settings. Also settings that serve persons with addiction and or substance use disorder, just given the high rates of substance use we see among our syphilis population, specifically our maternal syphilis population. Next slide, please. So that's all and great, but how do we actually go about doing this? Because that takes resources. Next slide, please. Well, Access has done a lot to increase access to testing, specifically in light of the high rates of syphilis that we are seeing. In the October release of the Medical Policy Manual, they now made a requirement that providers shall ensure members are tested for syphilis at least annually, beginning at age 15. And again, we're still respecting the autonomy to opt out of service, but the expectation is we create those testing opportunities for all members. And given the number of syphilis cases who are on access plans, we are optimistic that this will have a huge impact on our ability to identify cases and get them linked to treatment to disrupt community transmission. Next slide, please. In addition to that, there is a newly released differential adjusted payment program. So for those who are less familiar with what ADAPT is, essentially it is a positive adjustment to the access fee for service rates. So we know that implementation of ED screening does cost resources, right? So this program is designed to help offset those costs. Requirements for participating in the maternal syphilis DAP include having all females 15 to 44 presenting at hospital or ED to be screened for syphilis, and then when positive, they must receive that first dose of treatment because we're really, really trying to disrupt that community transmission that we're seeing with syphilis. And you can find more information about this new offering through the public notice and the policy standards documentation. The public comment period for the DAP has now closed, and we're hoping this will launch in early next year. Next slide, please. So the other thing that I would recommend if you're interested in leveraging an ER testing model is to seek advice from those who have done it. There are a lot of entities out there in the nation and in our state who have already implemented ER screening. I know a couple of clinics in Arizona are really close to implementation. We have a couple IHS clinics that have already gone live with ER screening. I've chatted with Dr. Safford from Houston about her Preg Out program. California has posted a lot of resources about how they operationalize ER screening. So you do not have to build these programs from scratch. You'll definitely want to build it with your clinic in mind because every clinic is a little bit unique. But there are tools that exist that can get you started, and we can help make those connections. Next slide, please. So to operationalize ER screening, you're definitely going to need clinic buy-in. I'm your public health champion. You've got a couple of public health champions on the call today. Always happy to help support with implementation, but you really do need that internal buy-in to get it off the ground because the more streamlined you can build it into your existing clinic flow and processes, the easier it is to implement successfully. So having that clinic champion, having people impacted by the process involved. Do you have an in-house lab? Do you have an out-of-house lab? Do you have a pharmacy, finance? What does your clinic look like? Those are the partners who's actually like interfacing with the patients. That's who you're going to want to think about when you're building this into your existing system. And again, I linked some of the tools that already exist from our AHS partners around operationalizing standing orders specifically to help implement ER screening. Next slide, please. So workflows and protocols that can help make this easier as far as lift goes is leveraging those standing orders. We have people who do testing and treatment in the field under standing orders. So it's very, very doable, even though you're working with benzathine penicillin, there are ways to, prepare for any adverse reactions when you're doing that field work. So if you can do it in the field, you can definitely do it in ER. Using that syndemic approach, syphilis does not travel alone. We see syphilis travel with HIV, Hep C, and pregnancy. So to the extent that you can bundle these services, that may reduce costs and improve impact of the efforts being provided. Using automated test ordering processes like EMR alerts can be helpful. Using tests that reduce lab turnaround time, so that rapid in-house testing in particular in the ER model has been very helpful. I'll talk a little bit more about the point of care tests that exist in a bit. Making sure staff are educated on the process. And again, as much as you can build it into your existing workflows, that makes it way easier to implement and sustain over the long run. And then having that benzathine on hand is important. Next slide, please. All right, so lab bundles, you can do a lot of different cool things with alerts depending on how fancy your IT is. I know that sometimes we work under limitations with IT, so this may not be an option for everyone, but I do like to mention it for those who have that ability to adapt their IT systems. You can do age-driven alerts to do 15 plus. The access requirement, there is no upper limit on that, so 15 plus should be screened. Diagnostic driven alerts, so for those who come in who are pregnant, you could leverage those types of alerts. You can leverage the chronic problem list to actually include the RPR in the notes to inform treatment. Again, not every setting is going to be doing those second and third doses that some of our late latent cases will need, but that can be really, really helpful for figuring out who actually needs treatment or not, or is this an historical infection or biological false positive, etc. And then you can also do custom lab bundles that just one click and you order everything. So again, not everyone has the IT capacity to do all these things, but they are things that can make the workflow a bit easier. Next slide. Okay, point of care testing options. Love talking about syphilis testing. There are now 3 point of care testing options available. Syphilis and ChemBio are both CLIA-waived tests. They've been around a little bit longer. The cool thing about ChemBio is it is a dual test. It's HIV and syphilis. So if you're looking at a syndemic strategy, that's a great one to use, but all of them essentially work the same. First to Know is the newest test that's available. That is actually something that you can pick up at a pharmacy. So there are new tests that are available. If you're using the point of care testing model, essentially what you are default using is a reverse screening algorithm for syphilis. So you start with the point of care test. If it is positive, then you're going to have to run a phlebotomy, full draw blood, and run the both the RPR and the confirmatory like TPPA test, because some of the folks who test positive on the rapid may not be a true positive. They may have had a historical infection, or they may have something else going on that triggered a positive. Either way, if you're using the rapid point of care test and you get a positive in that ED setting, we would recommend just doing that first dose of treatment, report it to public health as you would any reportable infectious disease, and public health can do the lean in to help with the follow-up that may be needed for that case. Next slide, please. So follow up. Again, you don't have to do it on. The Preg Out program that's running in Houston is awesome because they have an in-house clinic where once someone tests positive in emergent care, they get immediately referred. That's really nice. So the follow-up happens all within that one clinical setting. Not everyone has that. So if you have someone who tests positive, report it to public health and do that warm handoff, and we will take care of any follow-up testing and treatment that is needed if they need that second and third dose of treatment. That's what our county health departments can help coordinate, and that's what we can do at the state as well. We do follow up on all those reactives to ensure that folks are getting fully treated for their infections. Next slide, please. All right, so I covered a lot and I talked really fast. There will be time at the end for questions, but I do want to recap those objectives. We saw that congenital syphilis rates are increasing, particularly for those not in prenatal care. We saw that ED settings are a really important touch point that are serving clients that do not have access to care at all. And that's why we're making the recommendation to screen in the ED setting. And we saw that there are tools that can help support the implementation of ED screening models. And final slide, if you have questions that we don't have time to get to today, please do reach out. Our programmatic contact is sti@azdhs.gov. We've got a data request form. We've got our provider line. If you want testing, treatment histories, all of that stuff we can help with for continuity of care. And we've got even more data posted on our website, as well as some printable resources for providers and local public health professionals. Thanks, everyone.
Thank you so much, Becca, for the information you shared. I'm now going to turn it over to Rachel, who's going to talk to us about spots.
All right, I'm so excited to be able to present to you from a local health department in Pima County. We're going to talk about syphilis, pregnancy partner, onsite treatment, and support. We call it SPOTS. Next slide. We do have some learning objectives. I hope by the end of this presentation, you're going to feel comfortable in discussing congenital syphilis trends that are national and in Arizona. You're going to be able to review the current screening guidelines for syphilis in pregnant women and the general population. You're going to identify some barriers to effective screening and treatment of syphilis, and we're going to discuss some innovative ways to deliver syphilis treatment to patients unwilling or unable to access the traditional healthcare system. So I want to just kind of present a question, and we'll just stay at this slide for a while. Do you want to see a lower CS rate in your jurisdiction? You know, if you do, then I really want you to listen to what we're doing because I think it can help. I have an amazing team at Pima County. We've collaborated together. We've been able to sit down and really be innovative to say, what can we do to make this difference? Because as you see in this slide, it's just devastating to hear that we have these high rates, these numbers that went from single digits to in the 200s. So as we were sitting down with our partners, we were having our collaborative meeting. My colleague, Jill, who I just adore, Jill Weinstein, she said, you know, what can we do to make this better? And I said, well, let's not reinvent the wheel. Let's see what's already working. So we started to look at Louisiana. Louisiana put together a SHOT program, and they were making such transition changes from being in those high levels to dropping down and making such an effect. So I called and reached out to them. And this is where you just see colleagues that are playing partners and so supportive. I reached out to the director and I spoke to Laurencia, and I hope she's on the call today to give her a shout out of love. And she said, this is how we did it. This is exactly what we did. And they brought it to a state level. We're just bringing this to Pima County. But Laurencia said, even if you start small, it's going to be a ripple effect and it's worth it. So as we go through, just know that you can do this. This is absolutely possible if you've got people that have the passion to care about it and want to do it. So as you see in syphilis, we know exactly what Becca just said. We are there. We have a consistently high CS rate, and we have had for several years. When I came in, it was third in the nation, and now we're fourth. And that's just because we're behind South Dakota, New Mexico, and Mississippi. I think more people are testing, just like she said. But syphilis can affect anyone, and it's currently rising in women and men who have sex with women. And this has led to those alarming increases in those congenital syphilis rates. So we started looking at these CS cases specifically in our area in Pima County and identifying missed opportunities for screening that would have allowed for earlier diagnosis and more timely treatment. We put out this really cool poster, which I just love, to have that advertising opportunity. Don't guess, get a test. And I think if you start using these languages with your staff, you start using it when, you go around, everyone deserves to know what their syphilis status is. Have you seen our red, yellow poster with our red dots? And we have it all over our clinic. So it really gets people asking questions and start talking about different things. I've had, different families that come in for vaccines, and they see the poster and they say, what are the dots? What's all that? And so we get to have these great conversations. Next slide. So some of this is exactly what Becca has just been saying, but Arizona has an outbreak of syphilis among women and babies. And again, I know AZDHS is working to improve access to syphilis testing as well as in community awareness, because it's a growing epidemic and more people can have access to the information and treatment. So 449% increase. It is real. It is big. It is in our face. We cannot ignore it. We must deal with it. We need to protect ourselves and have these conversations with our patients using condoms when having any type of sex. And again, I'm just going to bring it out. It's oral sex. People are saying, I need to use a condom with oral sex. Yes. And showing them how to use any type of barriers for protection, opening up those condom packs, making sure they know how to put it on, reducing the number of sexual partners and getting tested regularly. I remind people, hey, our door's open. We're here 8 to 5. Come on in, let's get tested. We want to help you. So being able to really facilitate that is so important. As you look down on the bottom left, you see the number of babies born with syphilis that has increased each year. Becca was absolutely showing this information, and the percent of babies born with syphilis who were born stillborn or died, that 11%, that black top line. And then of those 136 babies born with syphilis in 2024, 13 died. I know that I met those mothers, and I've met many of them. And this has been something in 20 years of practice in Tucson. It's got my attention. I'm absolutely passionate about it. And anyone that knows me is going to have a conversation about syphilis and congenital syphilis and sex. And, it's just something that we are definitely known for, that we're passionate about treating this. So syphilis can lead to problems with skin, eyes, brain, stillbirth, and infant death. And up to 40% of untreated syphilitic pregnancies result in stillbirth or a newborn death. And babies who survive spend about 10 days in the hospital, and 13% of those babies were symptomatic in 2023. Let's go to our next slide. So we have a standard of care. Jess and Becca have said this, and you're going to hear this every single time that you hear a conversation about syphilis, and that is that it's asymptomatic. Sometimes people walk in and they say, I feel great. What are you talking about? I have no symptoms. I can't have a disease. So being able to do a tremendous amount of education that most syphilitic infections are asymptomatic at that time of diagnosis, and symptoms-based screening, would miss all of these infections. So we've got standards of care. We look at the U.S. Preventive Task Force Service, the USPSTF, to screen all pregnant women early for syphilis. I also love American College of Obstetrics and Gynecologists, ACOG, to screen all pregnant women for that 3 time frame. That first visit, that second trimester when they're looking at coming into the third, that 28 coming in to get their glucose test, and again at delivery, that 3-point screening. It sounds like it might be easy, right? But that's making those assumptions that everyone accesses prenatal care and can afford prenatal care and labs. And most of the time working here in the county, it's absolutely the opposite. I have no insurance. I have no PCP. I have no money. What are you going to do for me? But only 75% of those women are actually going to establish in that first trimester. When you're looking for women who are becoming pregnant, I really wish the dollar store would have a syphilis test right next to the pregnancy test and we can get it immediately. Wouldn't that be amazing? Because again, most women come in and they're usually out of that first trimester going into that second trimester. And 13% of them will deliver with inadequate prenatal care and 2% will deliver with no prenatal care at all. So again, if we have failure to screen all pregnant women at those points, we're going to miss those opportunities to identify, treat, and prevent congenital syphilis. Next slide. So we have barriers to care. Yes, we do. Missed opportunities and delayed prenatal care. So inadequate prenatal care, when we're looking at missed opportunities to screen, we're seeing there's the access to prenatal care, and that's the most important one, the main reason for not being screened in a timely manner. And common reasons: I don't have a car. Thank goodness in Pima County, the bus is free, but it doesn't mean that they make that. Even when we meet people in the field and we say, okay, here, take this Uber, sometimes they don't go where they're supposed to go. An ability to leave work or during clinic hours and childcare needs. So if you hear that, you can hear the passion that we said, well, we're going to go to you. We're going to find you. So that's going to be how SPOTS is going to overwhelm that. And overcome those barriers. And delayed lab results, missed opportunities to treat. Even if the diagnosis is made, not all offices carry the treatment, and all patients can return to the office for 3 injections 1 week apart. Okay, next slide. So if you have missed opportunities to treat, you have barriers to effective treatment. Office access. Not everybody has bicillin. Inadequate time to treat during pregnancy for syphilis. 3 doses over 3 weeks for patients with unknown duration of infection. Making those appointments within that 7 to 9 days. Late-term infection and reinfection of syphilis from untreated partners. That's my most passionate one, treating those EPTs that get ignored. They take great care of mama, but all of a sudden we forgot about the reinfection. Lack of prenatal coordination, whether it's financial or language barriers, not understanding. Fear of accessing prenatal care, documentation status, ongoing substance use, interpersonal violence, and then inability or hesitance to treat the partners. All of those are missed opportunities to treat. Every single one is a barrier that we must address. Next slide. Okay, so every one of those slides that I just presented to you is a great motivator for this program. So again, syphilis, pregnant partners, on-site treatment and support. That's what I want to offer to everyone in our Pima County area. And I hope you guys decide to offer this to your other healthcare departments in the state. Increasing access to treatment of syphilis for pregnant persons and their partners, especially patients who have been unwilling or unable to access syphilis treatment in a medical facility or at a Pima County Health Department. A team will make a scheduled home visit to treat the patient and the partner. We care so much. We're going to get in our cars. As soon as you put the referral in, you make the phone call and we are on it. Next slide. So my medical director, Dr. Saul, he always says a great phrase, no wrong door to initiate a referral. And I absolutely love that. It can come from anywhere. A case manager, a social worker. It doesn't have to come from an OBGYN. It can come from anywhere. So referrals for pregnant persons and their partners can happen through any opportunity, any door. A community prenatal care provider, PCHD clinic staff, WIC counselors, perinatal case managers. And referred cases are always evaluated using state STI records. We look through PRISM. We determine exactly the stage of syphilis and the treatment that needs to happen. And we always consider in-home treatment for consultation with dedicated nurse and clinician, and partner treatment. So even if the pregnant partner has been adequately treated, their partners are still eligible for the SPOTS program as contacts and can get tested and evaluated for treatment in home. So again, for any OBGYN, that's listening, If you've treated your patients, we'll take your partners. Don't think, oh, that's not my jam. I don't got to do it. No, we'll do it for you. And we really, really look forward to doing that. I do recommend, before we go to the next slide, that anyone who's doing this needs to be sure that they really have a solid perinatal nurse, someone, as your clinic is going through that you're sending out, making sure that those nurses that go understand how to test fully with their STIs, that you've got your links in place for, your CDIs or HIV and mesh testing or DES testing and linking to OBGYN care. So be sure your foundation is good. And if your foundation, is a little unsteady, then get that solid first and then initiate your SPOTS program. Next slide. So we had some secondary goals to decrease transmission of syphilis, and our other secondary goals are to decrease syphilis morbidity and mortality rates, to increase awareness of syphilis among community members and medical providers, and facilitate improved syphilis testing to cure monitoring using RPR titers. I do a lot of education and outreach. I go right down to medical assistants. I'll teach at JTED. I'll talk to LPNs. I'll talk to nurses. I'll talk to ER nurses. I will talk to anyone who has an ear to listen. And it makes a huge impact. You don't have to just think this is only for clinicians. This is for everyone. But as clinicians, if you're an NP, a PA, or an MD, DO, you play an important role in preventing syphilis and congenital syphilis. You got to know your signs and your symptoms so you can identify your chancres, you can identify your palmar rashes, your neurosyphilis. And if you feel unsure about that, look at the syphilis toolkits, just that Becca talks about. Reproductive Health National Training Centers, the RHNTC, I go there all the time and listen to podcasts, look at their syphilis toolkits. I love the Clinical Training Center also for Sexual and Reproductive Health, the CTC SRH. They are fantastic. Their syphilis tools are great as well. Making sure that you really get solid, like Becca was talking about in your EMR, for completing a sexual health history on every single one of your patients. Being sure that you've got those 5 Ps down, your partners, your practices, your protection, your past history of STIs, your pregnancy, and I even throw in PrEP. So just making sure that that's a part of your HPI. Testing sexually active people, not just focusing on MSM, remembering to test those, if you're testing for HIV, you're testing for syphilis, you're doing both at the same time, and not just throwing things out annually, but making sure you get, if they're HIV positive, you're looking at everything every 3 months. Really listen to your patients and hear if they have multiple sex partners, what their risk factors are, what they're doing. And it just makes such a great impact in finding your cases. And I can't say it again, really educating the public about 3-time testing for all pregnant women. First prenatal visit, at that 3rd trimester between that 28 and 30 weeks, and at delivery. And we know that's law, but just making sure to go back and have that. Next slide. Okay, workflow. So as soon as I get a referral and an intake process, we're going to immediately go into accessing inclusion and exclusion criteria. So if you're going to do one of these programs, our program basically is going to look at no history of penicillin allergy, meaning I'm going to go out and pick. And if they do have penicillin allergy, you've got to get them into the emergency room for desensitization. There's no other treatment for pregnancy. But for partners, if they've got allergies, you're looking at your doxycycline. Making sure you have a syphilis diagnosis and a staging, working well with an NP and an RN back and forth, making sure that's there. Having a cell phone service, a working landline. And the main reason for that is being able to communicate with your patient, being able to communicate when you're on site, and making sure that that patient has a zip code within 911 or EMS if it needs to be called. I don't anticipate that, but that's just a great safety parameter. Scheduling that home visit, making sure it's safety, patient's openness for treatment in the home, accessing the partner's needs, making sure that the partner knows, everybody has awareness, there's no surprises, reviewing PRISM data, and having a good relationship with the CDI to be sure, that you're not doing what they've already done. Like, oh, I've already got an appointment, that's on the books. So making sure that that's clear. Documenting the clinician order and treating the patient and the partner in their separate records, confirming the appointment and going to that home for treatment. Follow-up is really about communication, making sure that that post-visit EMR, we have ECW, making sure that that's updated, and providing that letter back to the provider that talked to you. So making sure that communication is, closed. That's the most important thing that we can do, is have good relationships with our outside providers. Next slide. So if you're going to do spots, you're going to need 2 people. We call it our travel team. Clinician and an RN or a medical assistant is going to go out. A lot of times I go out by myself, and then I meet somebody, grab them in the car. We both meet there at the house, and then we go in together. We always have a unified 2-person approach. You need to know BLS. You need to be trained in how to react with those EpiPens if anaphylaxis should occur. And you need to have your cell phone charged and ready, and 911 is essential if needed. Sometimes these neighborhoods are a little sketch, so you want to be sure that you're safe. Telehealth for the clinician and consultation can be helpful in the event if the team has a question. And just always being really supportive of anyone that's going to go out, knowing when they leave, having your phone there as an NP or the PA for any consultation and telehealth is so helpful. Next. Teaching people how to do a windshield survey before they go out, reevaluating suitability and safety for the home visit on arrival, obtaining verbal and written consent. You're going to get that verbal consent before you go. You're going to get that written consent as soon as you hit the door. And you're going to get it not only for the patient, but you're going to get it for the partner. You're going to complete that full history, and you're going to take that set of vitals and just keep using your time. How tall are you? How much do you weigh? How you been, how you feel, and take any needed specimens. We do everything when we go. It's going to be an HIV, RPR, TPPA collection. It's going to be a 3-site collection. It's going to be a throat swab, vag swab, rectal swab, all depending on their sexual practices. And then we're going to make sure that we review the treatment plan with them, administered medication, make sure you go back over, hey, we're going to see you next week, same time, same place. This is latent treatment, or hey, we are one and done. And observing any adverse reactions, do a lot of education in that 30-minute time frame that we have, giving them handouts, giving them links on their phone they can read about, anything that we can, making sure. We also offer vaccine mesh referrals for case management. And if they don't have PCPs, we definitely are, FQHC, federally qualified health center, linking them for care. Next. When we come in, we always do a post, the next slide, please, a post visit. And that's where the RN and the clinician are going to complete that proper documentation. Go back in the EHR. And if the treatment was not completed, the nurse documents the reason for incomplete treatment status. Sometimes it's not safe and you just don't go. Sometimes it is safe. Other people walk in, it's a compromise of confidentiality. But usually it's a, pretty anticipated 1, 2, 3 situation. Post-referral letters are completed and sent to the referring clinicians. And then obviously we do CDR updates and spots, clinician reviews, treatment and notes and referrals. So it's something that you're just watching constantly to be sure that everything is up to date and excels, and that everything that Epi needs is completed as well. And if unable to provide a complete treatment, the team continues the efforts to establish a treatment plan with the patient. We never give up on these. Next. So we were able to get into Pima County Health Department, the external provider referral form, which is in the bottom right hand and highlighted in red. And what we do is we just go out, we educate. We're like, hey, pop on the website, go right down there, fill out that external provider referral form that allows documentation to be sent, that allows ROIs back and forth, so that we have everything that we need prior to, going out to stage appropriately. And we know how much medication we need to bring and what conversations we need to have. Next. Again, syphilis is spreading fast in our community, in your community, in all of our communities. I hope if you need anything, you just reach out. Realize that Pima County Health Department is here. We love playing with other people. We've got a big sandbox. Everyone is welcome. External provider referral forms can come from anywhere. You guys can come down and shadow. We can talk. We can do whatever. It's just needs to be a very open door policy, like Dr. Saul says, no wrong door. And the only wrong question is the one that's not asked. So again, next we go into those, next slide, those questions. Perinatal nurse is usually there. Her name is Amy Higgs, and she definitely will pick that phone up. That's my direct line as well, 724-5334. You can email me, talk to me. We're ready to go. and make an impact on syphilis. Thank you so much for your time.
Thank you so much to Rachel and Becca for such great information today. It's now time for us to open up for our question and answer portion. As a reminder, you can add your questions or comments in the Q&A section. So feel free to add questions. We'll facilitate. I'm Dr. Sherry Brown, one of the senior medical directors with Blue Cross Blue Shield of Arizona, and I'm going to kick us off on the questions. So first question we have is, what are the unique factors or challenges contributing to the rise in congenital syphilis cases in Arizona?
Yeah, I think unlike other infectious diseases, syphilis is truly quite sneaky. Again, because it doesn't often present with noticeable symptoms, it really relies on good access to routine screening and treatment. And we know that we have many communities that just don't have great access to care or prenatal care. We've got a lot of care deserts in our state, and that is probably one of the most challenging things we face with control.
Makes total sense.
I'd love to add in if I could. And I think that we need to get uncomfortable in our comfortability with our patients, making sure that we make no assumptions, make sure that we go back and see that we have tested for syphilis, that we have done vaginal exams, that we have done rectal exams, that we start really getting more uncomfortable as clinicians and start to say, hey, I'm going to make no assumptions. I'm going to know for sure, for solid, for certain, exactly where my patient stands. And you'll be surprised how people come in with rashes or something that they're treating for dermatitis, and it's actually syphilis. So I've had situations where, I'm talking to providers and they're like, I had no clue. I just drew that RPR. I didn't do that reverse algorithm. And I think it's really important just to never be arrogant and saying like, I got this. No, we don't got this. And coming back and restarting over, listening to podcasts, coming back, doing those exams, and really making ourselves get to the place where we start having conversations with patients, no matter what the age, if they're sexually active. Have you been tested? Let's do that. And really knowing where it is. So I think that's very helpful for us.
I love that. You're absolutely right. Next question we have is, how many CDI investigators does Pima County have? And are they part of the team that goes to people's houses or parks, et cetera?
So we have many CDIs. So we have a wonderful epi staff that are there. And no, we don't pull them with us. We communicate, we look through, we make sure how things are. But yes, they're observers and we are hands-on action. So they're not going to, communicate that medical information, but they're going to have that observance to know exactly what's happened, in ERs and outside, locations, so that when we go with accurate, up-to-date confirmation, and we treat, again, not just focusing on syphilis, but looking at chlamydia, gonorrhea, HIV, all of it, and make sure that, we gather that data for them too.
Makes total sense. Thank you. The next question is, how are healthcare providers being educated and supported to prevent and manage congenital syphilis?
Great question. So education often happens a lot at the local level. We also do have several initiatives at the statewide level to provide access to education for providers. Some of the things that we host annually include like our clinical update, which will be, I forget the dates. I will put the dates in the chat. That's a really great space where you can come and learn about syphilis and how to prevent it in the community. And then again, on our resources page where we post tools for providers and public health, we've also got a new training section that will link to some educational opportunities, some of which include CME for those providers in need of CME.
That's fantastic information, a wonderful resource for our community to use. Next question is, are there any gaps in resources or support that need to be addressed to better combat congenital syphilis?
I'll take this one. All of those missed barriers, every single thing. Yes, they're huge gaps. I can tell you, I had hoped that all the pregnant women would come to Pima County Health Department, that everybody was coming through. And it was one of the good things that we did, to present to our leadership is we looked back and we said, they're not coming through our doors. So we need to go to them. And being public health, it's wonderful to be able to say we can. We have county cars. We have everything we can put in lock boxes, and we can take BIC in a cooler, and we can get going. So it was really wonderful to be able to bring that to leadership and to come up with spots and to put that into application.
That's fantastic to hear. And this is actually for you, Rachel, as well. Outside of spots, can you share any innovative solutions or approaches that have shown promise in other regions or states?
Well, yeah, the first thing I said was, congrats to Louisiana. Look at their shots program. And, Houston is doing great too with emergency rooms that, Becca just commented on. And I think, if you look for people who want to make differences, they make differences. And so, again, we're not reinventing the wheel. It's already out there. All of those things are there. People are sharing like crazy, like this was easy, this was done. We started also, as a clinician, we were going out into unhoused populations and bringing BIC with us, doing DPPs on site. You're able to really do it and get it done if, you just put your shoes on and get going. You just got to get out there and find them. And people are very willing to get tested. It's amazing to me when you tell them, hey, I care about you and your baby. Would you like to know your syphilis status? Every single person that I usually encounter says, yeah, that'd be great. Could you do that for me right now in the middle of this field in this unhoused population park? And I'm like, I can. And so we do it. And so while you're waiting for those results to come back in 20 minutes, you have the whole conversation with them so that if it's positive, they are prepared, ready, injection, go. So it's a good thing. And I think all of this information is out there. You just got to click and open. We have the internet and it's available.
I love that. Thank you. Dr. Taylor was able to join us today, and she has a question for you. So I'll turn it over to her.
Yeah, well, it's not a question, but I'm responding to one of the other questions where someone asked what some of the barriers are with regards to prevention of congenital syphilis. And I think it's important for us to recognize this in a broader scheme of healthcare, and recognizing also some of the key risk factors of congenital syphilis have to do with maternal access and particularly uptake of antenatal care, and also the high contribution of drug use. And recognizing that a lot of these women are not experiencing a planned pregnancy. This may not be a wanted pregnancy. They may not have the ability to care for themselves during pregnancy, and they may not have the intention to care for the infant. We find that a lot of these infants who are born with congenital syphilis are placed in foster care or placed up for adoption. We do need to recognize that there may be a situation of an inadequate access to family planning. I know that's a very controversial topic, and I'm expressing this opinion in a personal capacity, not on behalf of my agencies, not on behalf of ADHS or CDC or Public Health Service. But I do think we have to recognize that when women are actively using substances, they are not using any type of pregnancy protection, that they may not be intending to get pregnant, may not want to be pregnant, and may need to be offered family planning services. So as a barrier, this may be one we need to address through maternal child health and through family planning. Thank you.
Thank you. That's incredible information, Dr. Taylor, and I absolutely agree. I know we have time probably just for one more question before we wrap up. I see there's a couple of questions, and what isn't addressed, we'll try to address as well in writing. But for the most part, how can we ensure that our efforts are inclusive and reach the most vulnerable population?
Great question. I think kind of going back to some of the strategies we shared around how you offer testing really matters. Being able to offer it to everyone, being able to contextualize it within the fact this is something that we collectively all are facing will help reduce some of the stigma. STIs are still heavily stigmatized. Substance use is very, very heavily stigmatized. There's a lot of real fear that our clients face when accessing services, and they have a lot of negative experiences that can, in addition to other barriers they face, kind of drive why we're seeing the rates that we're seeing. So, just being able to open this, and usually I think Rachel's exactly right. When clients start talking about, when you start expressing that you're a safe person to talk to about sexual health, people open up real quick. I've had people open up to me in all sorts of setting, in the Uber to the airport for a conference. You can talk about sexual health really anywhere. And the more comfortable you get talking about it, the more at ease your clients will be and the more receptive folks will be to services.
That's wonderful. And last question before we wrap up, how can academic medical nursing faculty or students support these efforts? Do you guys need volunteers or do you accept any?
I love that. I've done lectures at all of those educational facilities in our city, which is great. And everybody always comes back and says, I want to help, I want to help. And I think volunteering at your health department, getting on board with, anyone who is doing anything positive for humanity is going to make a change in a positive way to support people, being seen, known, loved, and cared for, having empathy, realizing like, hey, I'm just a couple choices away from being unhoused myself, so, really seeing people for their value and then offering the education. So yeah, put your shoes on, come on down. We'll find something for you to do. I promise. You can come shadow, we can draw blood together, we can talk, we can go out, anywhere you want to. But yes, I think every single health department would welcome volunteers. And then as far as medical education is concerned, bringing in lectures, bringing in conversations to all people, not just higher education, remembering that anyone that is at the front of your office is your most powerful one, because that's the person who meets someone eye to eye and says, welcome, you're invited, come on in. Thank you.
Thank you so much to Becca and Rachel today for all your insights. The slides in today's recording will be available on the NARBA Institute's website in the next few days. As we conclude, I'd like to draw your attention to the QR code on the screen. Please use this link to express your interest in obtaining CEUs for today's talk and to provide feedback about what you would like to see in future sessions. We also send the material and survey link to all participants following this call. As we conclude, I'd like to extend a thank you to our partner, the NARBA Institute, who is instrumental in making Arizona Community Grand Rounds possible, and specifically to Mary Jo Gregory, Dr. Mark Carroll, Jessica Rigler, Carla Berg, and Jennifer Pierce for their collaboration. There will be another session in May, so keep an eye out for our email newsletter for more information to come. Thank you all so much for joining us today. Have a great day. Bye.